Patients who are suffering from amyotrophic lateral sclerosis can suffer from a set of symptoms referring to the upper motor neuron lesions, as well as we can have patients who are suffering from the lower motor neuron lesions. And in other cases, it can be a mixed picture, obviously exhibiting the upper motor neuron as well as the lower motor neurons in this particular case. Basically, it's a disease which is affecting the higher centers as well as the spinal cord as well as the peripheral nervous system. So it's going to be a mixed picture in cases of ALS. The lower motor neuron signs, as you can observe over here, it can be the weakness, as we even saw in case of Clinton. He was suffering from extreme fatigue. He was suffering from weakness. So these were the key features which were basically making the clinician or the physician suspicious that it might be a case of ALS, and obviously the further investigations were done accordingly. The muscle wasting can be one of the key features which is observed in these cases. And then we can have a hyporeflexia, that is diminished reflexes. It can be a knee jerk, it can be an ankle jerk. When you perform a complete motor neuronal examination on these patients, a diminishing of the reflexes is usually observed in these particular cases. Then muscle cramps is one of the criteria or one of the signs and symptoms that are usually observed. Fasciculations are basically referring to the twitching movements that are usually observed. Fasciculations occur when the uninhibited nerve signals are passed on to muscles. For instance, everybody has observed the blinking of the eye or the twitching of the eye muscles that is observed usually when a person gets anxious. So it's a normal fasciculating phenomena. But an increased or enhanced presence of the fasciculations in the limbs, for instance, can make an individual suspicious of the fact that ALS might be the diagnosis in this particular case. And obviously, it is coupled up with the lack of the sensory signs and symptoms in the patient, because that is going to exclude ALS completely in that particular scenario. So you'd be focusing on the presence of symptoms as well as what symptoms are absent, and that is going to help you out in making out a differential in these particular cases. The upper motor neuronal signs include the spasticity. Spasticity is basically an increased tone in the muscles. It can be the muscles of the back. Usually the muscles of the back are affected by the spastic phenomena, and the patient can even tell you a rigidity that he observes in the muscles of the back. So this can be one of the phenomena that is observed. Then we can have hyperreflexia, which would be an upper motor neuronal sign, and extreme fatigue, generalized weakness is one of the signs and symptoms as well. Then we have an asymmetrical weakness. When you observe or when you basically conduct the neuronal examination, the nervous system examination, you would find that there is a weakness which is not symmetrical on both sides. Onset of single limb or bulbar onset of the symptoms is one of the key features. Then we can have a local spread, then regional spread. So it's not the whole region which is usually involved, but a certain portion. It can be, usually it starts off proximally and then goes off distally. So this is the usual presentation of signs and symptoms in this particular case. Fasciculations, as I've already told, it's basically the uninhibited neuronal injections towards the muscles that are leading to these involuntary tremors in the muscles, either the limbs or the upper limb or the lower limb. Apart from the upper motor neuronal signs and the lower motor neuronal signs, the patient might exhibit the atypical features. For instance, we can have the features such as dementia, loss of memory is one of the signs and symptoms observed. Then sensory loss, as I've already told, usually the typical picture of ALS doesn't show a sensory loss, doesn't show numbness, doesn't show paresthesias, but there are certain exceptions in which we saw sensory loss as well, complaint of paresthesias as well, oculomotor dysfunction. So these are all the atypical features. They're usually not exhibited by the patient, but if there is a diagnosis of exclusion and you have excluded all the other causes and the only diagnosis left is ALS, then you can refer to this particular diagnosis. Oculomotor dysfunction, obviously, the cranial nerves are also involved. The oculomotor nerve, third, fourth, fifth, and sixth cranial nerves are involved usually in the process of ALS. So it might exhibit an oculomotor dysfunction as well. Then usually there is a bowel or bladder dysfunction that is also seen in these patients. So these are not a typical picture. This is not usually the case with ALS, but patients might exhibit these signs and symptoms, and you have to keep that in mind as well. Majorly, you have to focus on the upper motor neuronal signs and the lower motor neuronal signs because it is a motor neuronal degenerative disease. So as the pathogenesis is indicating, it is only going to affect the motor neurons either in the periphery or in the central nervous system, and simultaneously it is going to exhibit the neuronal signs in that particular manner.